Hello, my name is Joel Dunning. We're here at the STS 2024. I'm delighted to be here with Justin Blasberg. You're Associate Professor at Yale, and you have literally just got off the stage where you've been presenting a really interesting study about the longitudinal follow-up of esophageal cancer, and you've managed to pair up two databases to really give some very interesting findings that I think we can all learn from. Maybe if you could start by just telling us the key points that you have literally just presented.
Sure. So, we're very familiar with the STS database, and it's a rich database with a lot of granular information, especially about our esophageal cancer patients and our patients who undergo esophagectomy. I think we were very interested in pairing such a database and linking it with longitudinal outcomes. And the best way to do that was really to pair it with CMS claims, inpatient claims. And so we were able to successfully link about 5,000 patients over a 10-year period. We were able to look at patient, hospital, surgeon, tumor-specific characteristics, and really define specific risk factors for both long-term mortality risk as well as readmission.
And this is stuff we don't really see when we just look at the STS database. So us as surgeons, if we can get them out the door, then they've managed it. But actually, this study shows that's not the case, isn't it? There really is quite a high rate of mortality and readmission.
Right. So especially for our advanced stage patients, we generally think of 90-day survival as being about 2 times the 30-day survival risk. And for all comers in the study, that 90-day mortality risk was somewhere around 7%. But when you stratify it by stage and you look to see which patients are most at risk, the stage 3 patients in particular had a 12% risk of 90-day mortality. And then when you follow that out over time at 1 year and then at 5 years, the curves start to look more like what we would expect from the AJCC survival outcomes that have been published previously. So I think there are opportunities to see specifically or to identify specifically patients who are at risk for short-term mortality, 90-day mortality, increased risk of readmission for stage 2 and stage 3 patients. We saw 50 and 60% of those patients actually being readmitted to the hospital within 1 year, and in some cases multiple times. Those are patients who have recurrent disease or developing infection or aspiration. And so I think there are opportunities for quality improvement and for maybe changing the outcomes in a positive way by recognizing the patients who are at highest risk.
Yeah, I mean, that's pretty amazing, really, isn't it? 1 in 9 mortality, and half of your patients are going to be readmitted. So, I mean, is that a message to us all that we should, follow them up more closely? We should keep, closer to them once they've left the hospital.
Well, I think the message is that we can predict this with with a little bit more granularity, and so I don't think all patients need to be looked at with such a close lens. But I think we can parse out specifically looking at what a patient's response was to neoadjuvant therapy, what comorbidities they may or may not have, and then using sort of those characteristics and these models to define which patients maybe should have a closer follow-up, should have a different a pattern of surveillance or endoscopy, maybe even to expand the indications for adjuvant therapy. And so I think there's a number of possible ways to change those long-term outcomes, but I think that the purpose of the study was really to highlight the prognostic significance and to specifically identify the patients who are at highest risk.
Yeah, but it's a really nice study because no patient comes to saying, I'd like a 30-day survival, please. Everybody wants to live longer, don't they? They want to live to the year and to the length of follow-up that you've provided for us, really. So actually, this is the way we should be going in the future, really, isn't it? We should be seeing our own 1-year mortalities and longer-term mortalities. Do you think this is something we need to do more and more in the future, really?
Well, I think the next step is we've identified that the response to neoadjuvant therapy predicts short and long-term mortality and readmission risk. And I think the idea that it would be possible to define that response to neoadjuvant therapy pre-surgery as a way of risk stratifying patients to surgery, saying, here's a patient who had successful downstaging of their disease pre-surgery, and so it makes sense to proceed with surgery, or here's a patient who has persistent nodal disease or even upstaging of disease pre-surgery, and it makes sense for us to maybe think about non-surgical pathways. So there is an opportunity here that we don't currently explore in esophageal cancer or even lung cancer when we think about neoadjuvant therapy, and it may be an opportunity that changes some of these numbers in a positive way.
Yeah, so it's extra armory for us to actually be more nuanced. And you mentioned thoracic lung cancer surgery. Have you managed to successfully pair up the STS and CMS use for thoracic surgery as well. Is
So
there another paper coming?
I'm fortunate to stand on the shoulder of giants, and that was a manuscript that was published in 2016. The STS General Thoracic Surgery Database Task Force was able to create that linkage for lung cancer and found some really interesting and similar types of relationships. But I think there's a lot of value, and as we see the value in these linkages, the STS is continuing to see value in following out patients longer and itself having long-term outcomes as part of their database and as part of the record keeping for these patients.
Yeah, fantastic. And do you think there's, I suppose now chemo IO and immunotherapy comes in, there's a need to relook at that, because I guess there have been waves of changes, haven't they, in our regimes? So how do you think that'll affect the data?
Well, it's an exciting space. We talked about that today in our session, actually. Looked at both some older neoadjuvant trials. They're not old, they're old by in 2024, but also what's on the horizon, and even data that's maturing as we go. And certainly there's an ongoing conversation about which drugs to use and whether to use them before, during, or after surgery. And I think that conversation and that data will mature over time as well. But it's an exciting space and an exciting time to be in thoracic surgery.
Yeah, and just to wind up, so what do you think the next 5 years is like in this esophageal space? Do you think we'll have more gentle regimes, more immunotherapy, or how do you think the next 5 years is going to go?
Well, the surgery has been very successful for certain groups of patients. The idea of multimodal therapy and which patients should get which treatments, I think, represents a space where there's new data and sort of an adjustment as to how we're thinking. Should patients get neoadjuvant chemotherapy and radiation, or should they just get chemotherapy alone? And I think that's what the next series of trials are looking at, is to sort of optimize how you can use multimodal therapy for these patients. And hopefully in terms of things like short-term or long-term risk for mortality, we see improvements because we're fine-tuning those different tools. So
great. Well, thank you so much for coming straight off the stage to talk to us. Really great presentation, and it was a pleasure to talk to you. So thank you so much, Justin.
Appreciate it. Thank you.
Thanks a lot.
Have a good day.